This is what we train for. As you can see from the AI that was generated, from Module 1 to the CST exam, it is your time. Hello, everyone, and welcome to our last session together for ST 710, the CST exam prep. We are in week 11. So for our agenda, whew, well, we have some practice questions that we're going to do. We are officially in the refinement mode. I want you to just remember, even my Mod 6, you guys have come such a long way. And now it's about locking in what you know, catching those small little patterns that we've gone over the last 10 weeks, and fine-tuning your instincts before the real CST exam. So this is going to be your chance to kind of simulate under exam pressure a little bit. I got to make sure I did it anonymous. We have 30 questions that we're going to go through. We'll take a 10-minute break, as you guys see. We'll go over our stress management tip, and then we focus, refine, rehearse, recover. I think our PD is going to stop in before we get out of here to give you guys some words, some encouragement, and that'll be it. But before we get into all of that, you know we have our quote of the week. Believe you can, and you're halfway there. Again, here we are at week 11, the final week of our module. As you face that mock CST exam and you prepare for the official CST exam, I want you to remember those words. Believe you can, and you're halfway there. Right now, your belief in yourself matters more than ever. You have spent months, a year or so, right? Studying, practicing, and pushing through challenges. You've built the skills, you have the knowledge, you have the resilience needed to succeed. Now it's about trusting everything that you have already done. Believe in your preparation, believe in your growth, believe in your ability to finish strong. You are not the same person who started this journey back in Module 1. Think about it. You are ready to step into your career with strength, skill, and pride. It's kind of cool because the finish line is right there. It's in sight. And I believe, in my humble opinion, that you are more than ready to cross it. So let's go. Now, before we even get into tonight's subject, I had a student reach out to me and sent me 4 questions. Okay. I don't want to put that individual on, front, but I am very grateful because it kind of gave me something to kind of like focus before we jump into your questions. All right. And I wanted to kind of go over them with everyone because you never know. Someone else may have that same question and didn't realize it. And they're like, aha. So now I'm going to go over those 4 questions. So the very first question that was brought to me was the catheter below would be used for, and you have your 4 options. Now, as you're looking at this, because you may have a question with an image, I want you to first observe what you see. Okay. Is it long, short? We know that it's a long catheter. The tip is straight. It does appear rigid and flexible. And we look at the attachment. Okay. So we ask ourselves, what kind of path inside of the body might require a catheter like this long and narrow? And I love that you guys are throwing your answers out there. I love that. Okay. So now, because I'm not giving you the answer yet, now let's look close at the options. The common bile duct. This is narrow. It has a winding structure that will require a flexible and long catheter. Okay. We look at the artery. We look at the structural demands of placing something inside an artery. We have to think about the characteristics. The catheter has to be able to move safely through that artery. When we look at veins, how does venous access differ from arterial access? Okay. When you're looking at that, is it less pressurized or is it more direct? If we choose both A and D, or both B and C, which is the bottom one, can a single catheter be safely used in both types of vessels? With the same length, would it be the same pressure tolerance? And the tip design apply equally to both? All right. Then we go back to the functional question. What is the primary purpose of this catheter? Is it more likely used to drain, deliver, contrast, or navigate deep internal paths? Okay, look at the length again. When we look up here to see how many people, I've got two individuals got the correct answer. One doesn't count, but you count. Two individuals got the right answer. Now, what kind of anatomical structure would require this much flexibility and reach? So we go back to what I was mentioning before. Let's go back to A. Its narrow, winding structure requires a flexible and long catheter. So out of those again, are you who have given your answer sticking with the same one? Or are you going to change a little bit? A, B, C, or D? The correct answer is A. Your common bile duct is what we're going to use a Fogarty catheter for. Now, before we ask any more questions, there is a follow-up question that was sent to me that I'm going to break down as well. So keep that in mind because I have it kind of in order, okay? The next question that was sent. Now, this particular question, if you got it correct, because the individual who sent it to me actually got it correct and it was marked incorrect, but I don't have the quiz number and I don't have the week. So please send that to me so that I can go through and correct it before grades are in, because I can still correct as much as I can before we get our final grades in. Okay. So this particular question, the individual who sent it to me had the correct answer, but it was marked incorrect. Okay. Now, if you have a question about the last question, save that one because we're going to break this down even more. Okay. So I see that there is a question, but save it because we are going to break this item down a little bit more. Okay. And I kind of want to make sure that we are staying a little bit on track. Okay. Because I already have it. Luckily, the individual who sent this to me had already follow-on questions and they were amazing. So I'm able to kind of build up on it. Okay. Now, again, if you got this question and it was marked wrong, all I need is one person to let me know the week and quiz or knowledge check. That way I can go through. Okay. Now, the question, of course, thick plaque that causes blockage in the arteries. You had A, B, C, or D. Okay. Again, the person who sent this to me, you cannot answer. Okay. Because you got it right. Um, but everyone else, the answer is A. Why? Because we're talking about plaque buildup. Okay. And the question specifically asks thick plaque that causes blockage in the arteries is arteriosclerosis, not to get confused with arterial sclerosis, which is a stationary clot, versus a thrombus, which is a traveling obstruction. Okay. Again, with the classes that I have, I do not have the time to kind of go through each quiz, all 10 quizzes to figure out which one. So if you guys could please help me out, that way I can correct this ASAP for y'all. Okay. Again, I just need one person because as soon as that one person sends it to me, I'll know which week, and then I'm going to go through everybody that has taken that quiz, which is all of you. Okay. Now, I told you I was coming back around. Okay. We look at the name of this instrument below. A, B, C, or D. Now, we have Red Robin, Fogarty, embolectomy, Mellicott or Fogarty biliary catheter. This is actually a Fogarty embolectomy. And so I grabbed some images to kind of break these down. Okay. So the first question asked about where we would use it. The second one in this group asked what it was. And we're going to break it down a little bit more because there's still one question in this group that's going to kind of bring it all together. The Fogarty embolectomy catheter has that small inflatable balloon near the tip. Okay, it is designed to be inserted past an obstruction like a thrombus or stone because it has that balloon that is inflated. So it'll go past whatever the object is, blood clot, stone, it'll be blown up and then it'll be brought back. If you've done any thrombolectomies, you've seen it, you've done it, you know how it works. It's gently withdrawn, so we're not going to yank it out, but we gently withdraw it, pulling the blockage out with it. Now, that function is exactly what's needed when clearing a stone from the common bile duct, even though its name suggests it's for blood vessels. Now, it may be readily available, of course, on our sterile fields. It comes in micro sizes, 2 to 3 French, which is ideal for those narrow diameters. Okay. Now, surgeons are familiar with its performance in a lot of delicate spaces. The action, inflate, sweep, remove, is mechanically appropriate for dislodging stones. So a lot of times when we look at it and we're like, it's a Fogarty embolectomy, we are thinking, oh, it's just for blood clots and different things. But now it's almost like the Red Robin. Okay, if we go back to the Red Robin, and if anybody has done ENT, okay, we use this Red Robin when we're doing tonsillectomies, right? Where the surgeon will take the Red Robin through one nostril, pull it up through the adenoid, back through the other nostril, and clamp it out of the way. So it's that same instrument used in a completely different service. Because what is a Red Robin initially used for? Straight cath. Put it into the urethra, we drain the bladder, and we're boom, bada bing, we're done. But just like the Red Robin has multiple purposes, so does the Fogarty embolectomy catheter. It has different functions that can be used across multiple services. Now, you're probably thinking, but what about that Fogarty biliary catheter or the Mellicott, right? Okay, well, the Mellicott, if you remember, it's winged. It's going to be used for drainage. This is for a nephrostomy. Okay, now I'm going too fast. Hold on, guys. Now for the Fogarty biliary catheter, and I hope I'm saying it right. I'm always like, now this one is specifically designed for the bile duct clearance, but it's going to look different from vascular Fogarty's, right? You look at the balloon's going to be a little bit longer. Of course, this is AI, so it's not the perfect one. The thing to remember is the Fogarty embolectomy catheter is designed for vascular use, right? We got it. But it is small. It has an inflatable balloon tip that makes it highly effective for clearing out those stones or obstructions in narrow ducts, including the common bile duct. This is a great example, just like a cross specialty instrument where we have a tool designed for one system, vascular in this case, but it's repurposed for another, biliary, due to its similar anatomy and function. Right. So Catherine brought up a great point. Of course, I was using AI because I want to kind of use our own information, but the picture isn't exactly correct because it's AI. Okay. So one of the biggest things to do is to just make sure you guys go back and really look at the Fogarty embolectomy catheter versus the Fogarty biliary catheter. And you'll notice the tip is going to be a lot longer. So it's a lot longer and flatter. Okay. Again, working with the best we can for AI. But I highly encourage you guys to go back and trust, but verify. Trust what I'm saying, but verify for yourself so that you know that you know that you know. Okay. Again, surgeon may ask for a Fogarty embolectomy catheter during a cholecystectomy. Why? Because the balloon is designed to allow safe, gentle removal of different obstructions. Though we know that it's made for blood clots, it is effective because it can go past the obstruction, we can blow it up and bring it out for clearing things like stones. Does that make sense? It's kind of quiet today. All right, but I'm not done. Again, we were here. Sometimes it's not about what the tool is named. And that's a lot of times what we get caught up on because we want the technical term. We know we look at it and we're like, this is what this is for. This is what the term means. Sometimes it's about what it can do safely and effectively. This is going to be a perfect example of how we use instrument applications because this is actually real world where that one time when we bring it together where something that we use for one purpose is directly used in a whole nother setting to do a safe job for our patients. Now, Noreen, did that answer something that you were going to ask, or was it completely opposite?
Okay, yeah, I was going to ask about the catheter because I changed my answer in the quiz when I saw the same picture in a different question asking about embolectomy catheter. Saying, oh, this is for vein and not the common bile. So I went back and changed my answer and it was wrong. So I was confused about that, but now you cleared it up. And another thing, I was reviewing the quiz. I don't know if I should mention it right now, but it's kind of, oh, you just said it. That's why. For the plaque in the artery,
It's correct. So if you're
it's
one of the ones, because I just don't know what quiz it is, was it last week's quiz?
it's week 9.
Week 9. Okay, thank you, thank you, thank you.
Week 9, question number 67 for me.
Okay.
So I chose, believe 100%. I know it's the correct answer, which is atherosclerosis,
Yep.
and it's marked wrong.
Yeah,
I
yep.
just
No, that's
saw it.
perfectly fine. That's why we are here to kind of fix it. And now that I know what
Yeah.
quiz it is, everyone, I'm gonna try to get that done today.
Well,
Don't
there
quote
is
me.
another wrong marked question
Yeah,
I want to correct.
yeah. And
It's
I think I'm about to cover it right now because you had a really good helper. I just wanted to throw that person out there. Thank you, thank you. Because this may be the question. Let's see. Let's see if this is it. This was another question that if you had it marked wrong, I will be going back and looking. And now that I know that it's week 9, I'm able to kind of go back and, check out those 2 questions in particular. Like I'm going to be focused on that. So if there's something else that comes up, y'all have to send me because I'm going to have tunnel vision, like I'm a surgeon, and be looking directly for those 2 questions. But which of the following is not a muscle classification? Smooth muscle, cardiac muscle, skeletal muscle, which only leaves elastic. So again, if you had this one marked incorrectly, now that I know what week again, I'll be able to take care of that this evening. If I can't get it to this evening, it will definitely be, you should definitely see an update by tomorrow afternoon. Just depends on, everything else. Now, if there's anything else that you feel was marked incorrectly, you guys, please let me know. Again, sooner rather than later, just so that it makes it a lot easier. Yes.
Yeah, there is another question in week 10. You want me to say it right now or send it
Send
to
it to
you?
me because then I can check everybody's. Yeah.
Okay, sure.
Yeah. Thank you.
Thank you. You're
And I'll
welcome.
be on the lookout for it. And that's for everybody. Okay, you guys. If you notice something, let me know as soon as possible because as y'all know, this is week 11. So the quicker we can kind of close up business and get everything done, the less stress we all will have. Okay. Any questions on that? Did that help clear up those four, especially the ones that were marked wrong that you guys know you're going to be getting credit back for it? Okay. Now, whew, I believe we have to just check with Miss Shrooms. Shrooms, she should be here this evening. I know she was going to talk to you guys. If for some reason she isn't coming in, I see Samantha said it is this Friday. I will make sure to just verify and then send you guys a message as well. But Samantha said yes. So again, trust but verify. I will be verifying with Miss Shrooms for you guys. Okay. Now, okay, great. I love it. We are helping each other. Friday, mock, actual next Wednesday. Whew. It's like I'm getting excited for you guys. Not envious, but excited. Okay, so I got some questions based on the North Star. You may not know, but the North Star is what I used to pass my CST exam eons ago. I'm not even sure if the North Star is still in publication, but I did grab some questions and concepts to create 30 questions for you guys. Okay. And this is for 600 and 700. I believe 600, you guys are getting ready to take your first mock. So this is really big. Okay. Now, with this, there are 30 questions. Okay. You're going to have 20 full minutes to take this. Do not stress, breathe, relax, take your 30 questions. You can turn off your cameras while you're doing this. And just like practice everything that we've done the last 10 weeks. When you're done, we're going to take our 10-minute break because that'll be around the time we'll take our 10-minute break. And then I grabbed some of the more difficult questions to break them down for you. So it's real time. Okay. So take your time. I'm going to get the clock started and I'm going to still be here, but I'm just going to be in the shadows. So if you guys send me questions, I can answer. Not from this quiz though. Okay. But if you have any other questions or something happens, I am here. And with that, good luck. Let's see. You cannot, is there anyone else who cannot see the questions? Because I have 47 individuals that are here. Try to refresh. Let me see. Because I only see 47 individuals as well, which should be correct. Because there's 48 in. It doesn't give it to me. Can everyone else see the quiz by just typing in a yes or no? Let me know. These are poll questions. Okay, so Monica can see. Okay. Clara, do me a favor and try to refresh and see if that helps. I'm gonna try to get off of here so that my mouth isn't a distractor. Just checking in, let you guys know in order for me to share the correct answers, I'm going to need more than about 50% of you guys to complete it. Right now, we're about 34%, just so you guys know. And there's 4 minutes and 23 seconds left. No pressure, just letting you guys know. All right. And that's okay. Just know that there was supposed to be an image for number 10, and it was caught, and it's a Wheatlander. So if you didn't get that one, don't let that stress you out. I'm getting ready to in the poll. I'm going to show the correct answers. Now we have a couple minutes to kind of review some of the questions before our break. I thought that was going to take a little bit longer, but that's okay. Now, again, I just grabbed 10 random questions from the poll so that we can kind of break them down. I'm going to keep up the correct answers as I go through this, but still kind of hone in on these questions. So the first question I got was a patient with diplopia and midfacial trauma likely has which Le Fort fracture? Okay. Now, again, the correct answer was A, but we've got to break it down. Y'all know we got to break it down. Okay. So, who remembers what diplopia is? And if you don't, that's okay. Diplopia is double vision. So that lets us know that there's some type of orbital involvement. Okay. When we look at mid facial trauma, that refers to an injury involving structures like the maxilla, the nasal bones, and of course our orbits. Now, this brings us back down to our Le Fort classifications. And if you've done plastics or a maxillofacial, then you may have done a Le Fort 1 or even a Le Fort 2. Okay, so, or even a Le Fort 3. Now, with a Le Fort 1, we're talking about a horizontal fracture. It's across the maxilla and above the teeth. Okay. Does not involve the orbits. So it's not going to be up here. We're looking at Le Fort 1 about here. Okay. Le Fort 2. This is a pyramidal fracture. It involves the nasal bone, the medial orbital rim, but it's less likely to cause severe diplopia. Okay, so we're looking more of like a fracture, kind of like this triangle. Okay, with a Le Fort 3, this is cranial facial disjunction, meaning there is separation of the midface from the cranial base. It includes your orbital floors and walls. Again, which fracture would most likely affect both the facial structure and eye function? I want you to think about the highest impact. And if you even if you don't like get a lot of exposure, if you're having a lot of exposure to Le Fort, go back to one is usually not going to be as bad. Two, okay, that is causing a little bit of damage, right? But three is going to be that highest. So we're talking about everything is going to be affected. Okay. With this question, we look at the setup for a facial trauma surgery. We have to recognize signs like diplopia because that's going to help us anticipate which instruments, positioning, or surgical prep might be required. And especially when we're talking about a possible Le Fort 3 injury, that's a lot. Okay. Keep in mind, you look at symptom to setup. We think about anticipating orbital involvement. We think Le Fort 3, cranial, facial disjunction, everything needs to be fixed. Okay, they may ask questions about facial fracture set. If we're going to use a paraosteal elevator, is it a freer that we may use? They may ask about wire cutters. Remember, we are going to have to wire the jaw shut or put arch bars or some type of plating system, which means we're also going to need screwdrivers, drills, and some type of fixation plates. And there may even be a need for orbital retractors. They may ask questions in this concept about positioning, supine with head stabilized, head drape, turban drape, eye protection, corneal shields, They may ask questions of how is the prep going to go? Hairline to upper chest. This is going to include your orbits and your nasal area. When you're taking the exam, this is what you should be thinking about. Will there be occlusion checks? Okay, keeping suction and mirror ready if they need it. With a Lefort 3, are the orbits involved? Which means we have to be able to expect delicate dissection near the eyes. Also, is the brain at risk? Now, if it is, that also lets you know that there's going to be either another team or you're going to be having stuff outside to set up for what service. Who else may need to be involved if the brain is involved? If they, that is correct. Neurosurgery may need to be because there could be a dural tear, or at least a precaution not to get near that. Okay. If you hear diplopia and see orbital bruising, think ahead. What's the surgeon going to need to reconstruct both function and form? And then ask, how can I have it ready before they even ask? This is going to kind of help you when you see these questions. If you also notice from that one Lefort question, how many other concepts can they bring from it? Okay. The next question that I grabbed, what complication can occur if the blood is not properly matched prior to transfusion? And of course, we have, you guys can check your answers. It is a hemolytic reaction. But just like with the last question and the 10 questions I grabbed, we're going to break it down because I want y'all to walk into that exam confident. Now, a hemolytic reaction is a destructive immune response triggered by the ABO, or it's the RH incompatibility, okay, meaning it's not matching. Red blood cells are being attacked by the host. So the blood's being in, but the host is like, this is foreign. This isn't what is supposed to be in here. And it's attacking it. And that's causing rapid hemolysis, leading to fever, chills, renal failure. And if it's not fixed, it can cause death. So we look at our other options. Disseminated intravascular coagulation. This is serious, but not a specific blood typing error. Again, we go back to what is the question asking. We talk about hypofibrinogenemia and hypocoagulation, say those 3 times. These are coagulation disorders. They're not going to be directly linked to a transfusion mismatch. Okay. Now, we go back to what is the immediate and direct result of giving the wrong blood type. This is going to help us to focus on antibody antigen incompatibility, meaning the blood this patient is receiving, it's just not working out, and we do not want this patient to become a fatality. Yes, I remember this answer by simply hemo means blood, because wrong blood. That's correct. I like how you kind of put that together. Now for the focus. How might we see this question integrated? If a patient starts showing signs of fever and dark urine shortly after a transfusion, what should you suspect first? And then how should your priorities shift in terms of safety and the surgical team's response? This is going to help you to recognize critical signs of hemolytic transfusion reaction because I just gave you some things to look out for. There's going to be dark urine shortly after transfusion. When you hear transfusion, just know the patient's getting blood. Then start thinking what could be going wrong. Okay. This is going to help you connect blood compatibility to immune response. Think about the role in rapid response during or even after a procedure. Okay. Now, giving the wrong blood type, antigen antibody mismatch, destruction of RBCs, hemolysis. That is what hemolysis is. It's the blood cells are just getting shot up, knocked out. They're not able to stand tall. Okay. That means that there's going to be sudden fever, sudden chills, back pain. Maybe they're having pain on their flank or side. There's going to be dark urine. What is the word for dark urine? Because they may not say dark urine on the CST. I want you guys to be able to recognize what they may say. Do you guys know what the word for dark urine is? You can look it up. Because remember, we're all here to help each other. It has hemo in it. Any takers? I'll come back to that one because you may see it as the word versus dark urine. Hypotension, restlessness, or anxiety. Some questions or related that they may bring up is what is going to be one thing that's going to be done immediately? Stop transfusion, right? Help maintain sterility. That's going to be for us. They're going to be looking at the urine output because we don't want the patient to go into renal failure. Again, have a crash cart, suction available. Assist in collecting blood, urine samples for workup. Close, very close. I see a term, hemo. I'm going to put it in here because I would say it wrong as well. Hemoglobinuria. Okay, hemoglobinuria, uremia. If you see this term, remember, this is dark urine, okay? Because they may not say dark urine. And I always say it, I always pronounce it crazy. So hemoglobin, that word, that word, dark urine, okay? Which lets us know that there may be some blood in the urine. All right. Last question before our break. What should a surgical technologist do if a patient's abdominal wound dehisces after extubation? Okay, we know that we're going to notify our circulator, cover the wound with sterile, saline, moistened towels. Now, again, we go back to medical terminology with wound dehiscence. We know that's an opening of a surgical wound, viscera, meaning the inside, may be exposed. Our first priority is to protect internal organs from dehiscence and contamination. So we cover with sterile, moist towels, we don't apply pressure, and we don't tape it closed. Okay. The one thing that, even if we're in real world, we have to think, how do we protect exposed viscera? And we're going to make sure that we call for help without making things worse. Again, we're going to be with our surgeon. So that's not necessarily going to be something that we particularly are going to be dealing with by ourselves. Okay. Now, if a patient's abdominal wound suddenly opens and the intestines are visible, how do you respond quickly to protect the patient without causing further harm? And what steps do you take while waiting for the surgical team? So think about applications of emergency response knowledge. Think about prioritization of patient safety and sterility under pressure, recognition of what not to do in a crisis. Okay. These are some of the questions that the CST is going to kind of throw at you. Concepts. All right. Now, what we're going to be looking at again, wound dehiscence, reopening of a surgical incision, evisceration, internal organs protrude through the wound. Some of the things they may say, would you apply pressure? Like they may throw a concept like that. We're not going to apply pressure. We're not going to attempt to reclose or tape the wound. We're going to immediately cover the viscera, sterile, moist saline towels or some type of dressing. We're going to maintain moisture to prevent drying and infection. We're going to notify our nurse. Again, for us, it's a little bit different because we're already scrubbed in, patient's already there, but keep that in mind. If the patient's awake, they're going to be kept calm, still. Try to relax them. They're going to come to us if possible. Okay. Like if it happened in the PACU. They just got extubated. They're going to come back to us in the operating room, most likely. And while they're doing that, they are going to be monitoring vitals. They may ask a question, what is our role? We keep the sterile field sterile. I don't know if I just said a double. We keep everything sterile. Okay. Again, common mistakes to avoid, some questions that you may see, some triggers. Taping the wound could cause bacteria. That's trigger. Leaving organs uncovered, risk of contamination. That's trigger. Applying dry dressing, well, we don't want that because think about it. The tissue is going to stick and cause damage. Imagine trying to pull intestines off a dry gauze. The pain itself, right? That could potentially happen. Now, if the wound opens and viscera are visible, our role is to protect, don't panic. Moist sterile towels, nothing more invasive. I want you to think like you're in a case, you're calm, it's a crisis, but you've got it. Kind of like your CST exam. Now, in certain cases, and this is an excellent question, what do we do if we've broken down the sterile field? In this particular case, you're going to grab sterile, and Nareen said it, you're going to grab sterile gowns, sterile gloves. You're usually you might have to open up a 3/4 sheet on your back table. If you have some places like at ours, we have just back table covers that we can open up real quick, and we're going to go because that patient has to come back immediately. Okay. A lot of times in patients like this, they may even have a policy where you don't break down. At our facility, we don't break down until our patients are extubated in the operating room, so it's a little different. But some places would say until you get the green light for the next patient to come back, then you can kind of keep your stuff there. When we do tonsils, we'll keep, because that's a surgical clean case, right? So for tonsils, we'll keep our stuff there until our patient is good to go and we've got the green light to kind of break down from recovery. So a lot of times it's facility based, but in a clutch, you grab what you need and you get ready for that patient. Does that help answer that? I'm kind of seeing if there's anything else that I may have missed. Okay. Okay. I did get a question that I want to address before your break. I know, you guys, please bear with me. I just want to make sure we get everything out because this is our last, hooyah. The question was a little bit further up. What about hematuria? Talking about the difference with hemogloburinemia. You made me say it again. Now, with that one, both involve blood-related substances in the urine, but they're going to be quite different in cause and appearance. Okay. When we talk about hematuria, which is actual blood in the urine, this is the presence of actual intact red blood cells, RBCs, in the urine. So it's actually going to be pink, red, or cola colored. And that's just going to depend on the amount of RBCs that have been found under a microscope. Okay. Now, for hematuria, we're talking about UTIs, kidney stones. Maybe the patient has had some type of trauma. They may even have bladder or kidney tumors, or I haven't seen it, but I have heard if a patient or if a person vigorously exercises, that's my excuse for not exercising as much as I should. All joking aside, but yeah, you could get that pinkish color, you could get blood in your urine. Now, for hemoglobinuria, this is actually, believe it or not, hemoglobin in the urine from lice RBCs that have kind of sloshed off. Okay. So the urine color, it's clear red or super dark brown. It's often, they often call it like a port wine in color. There are no intact RBCs seen because they have kind of sloughed or lysed off. You know, like when we do lysis of adhesions and we're just lysening off those adhesions off of, that's the same thing that's happening. The RBCs are lysed off. Now, the common cause for this one um, is intravascular hemolysis transfusions. Like it's from a transfusion reaction. They could have had a severe burn or even malaria. Now, I know this is kind of going a little bit deeper, but just to know, they have to have like a dipstick to kind of test whether this is positive for blood, um, due to like the activity of certain things in the blood, or if it's actual the lysis of the RBC, whether it's the real RBCs or just the shedding off of the RBCs. Does that make sense? Okay. Um, on that note, let me get down to our break, see if I can find where I put the break. I think I put it way down here because I was like, we're good. Okay, we're gonna find the break. You guys take a 10-minute and I will see you back for the next group or the next half of our week 11 live session. And I will find the break timer so you guys will know. But we are on a break. Okay. We're getting into the next question. Okay, this is question 4. This is on pharmacology and documentation. Okay. What should be done if a patient is exhibiting symptoms of malignant hypothermia? Okay, so of course we already know the answer, right? We discontinue. Okay. And we administer the dantrolene. That's one thing that we always hear about, right? Dantrolene, dantrolene, dantrolene. Now, we still got to kind of break it down, okay? MH is hypermetabolic crisis. It's going to be triggered by the anesthetic agents like SUX or any other volatile agent or gases. So, anesthesia is going to see like elevated CO2. The muscles may start to become rigid. There's going to be some type of hypothermia and, of course, tachycardia. Dantrolene is the only specific treatment. What it does is it go in and it kind of stops the calcium release and the skeletal muscles, which is really important. Now, we have to think about what uniquely reverses the dangerous condition of MH. The answer is always, always, always going to be dantrolene. This is that one time where we can say that term, right? Always, always, always is dantrolene. When we look at the CST focus, here's another concept that could be thrown at you. If the patient suddenly becomes rigid, tachycardic, and their CO2 levels kind of spike really high during surgery, what steps should you be ready to take? And what is the one drug that can actually reverse what's happening? And that kind of brings us back, right? To one, we've got to recognize that this is MH. And two, what do we do? What is that? What is that drug? Dantrolene. And then we're going to stop whatever could be causing it, which is usually SUX. Okay. Question. This is our 5th question. All right. Now here again, I don't have in like specifics questions that you guys may have gotten incorrect. So just keep that in mind. I just grabbed 10 random. For here, we're looking at conversion and math in surgery. Again, these questions are concepts from the North Star, but highly, highly, highly closely related to our CST. 195 milliliters equals how many tablespoons? Of course, the answer, that's correct, 13 tablespoons. So this one is just a standard conversion. 1 tablespoon equals 15 millimeters. So then you would just divide 195 by 15, equaling 13. Okay. The biggest thing is just remembering the conversion. Okay. Sometimes we mistaken 10 milliliters or teaspoon size, or we forget to divide properly. So this is one of those like just kind of breathe and trust that you know it. Now, if we were to see it more integrated, you're preparing a solution and the surgeon asks for 13 tablespoons, which they don't say tablespoons, but just go with it. How do you calculate the total volume in milliliters? And then we look at the key conversion rule. Again, we recall the conversion for 15 milliliters equals 1 tablespoon. So that's just the biggest thing for that one. The golden rule here is 1 tablespoon equals 15 milliliters. Okay. That's the biggest one for that. Okay. Now, what is the most likely result if epinephrine is injected inadvertently into a digit during local anesthesia? Of course, there's going to be some type of necrosis because of vasoconstriction. But just like with the other 5, we got to break it down. Epinephrine, okay, it's often mixed with local anesthetics like lidocaine. Why? We want to prolong the anesthesia and reduce the bleeding via vasoconstriction. However, remember your fingers, your toes, your nose, genitalia, they have in arterial circulation, meaning they're going to lack that rich collateral blood flow. Okay. That means injecting epinephrine in these small terminal vascular areas is going to cause prolonged vasoconstriction without having alternate blood routes. This can lead to ischemia, then necrosis, the tissue starts to die, which is often irreversible. Okay. If a surgeon asks for lidocaine with epinephrine for a finger procedure, what is one thing that we're going to be thinking? How does us understanding circulation help to kind of protect this patient? Like, hey, doc, are you sure you want to put epinephrine? Remember, we're working on the fingers. Okay. This is one where we just have to be able to be that patient advocate when we speak up, because this is a high stakes scenario. All right. Biggest thing is epinephrine equals vasoconstrictor. We know we often are handing it up with lidocaine because we're trying to reduce bleeding and we're trying to prolong anesthesia. But again, we aren't using it in the fingers, the toes, the nose, the genitalia, for that reason. We can, because we're going to amputate the toe anyway, and we want the patient to have a more of a numbing effect. So great question. All right. Number 7. What is the primary surgical concern when a patient is placed in the Trendelenburg position for a laparoscopic procedure? Granted, I know this patient's in supine or in did I do it correctly? I'm trying to look at my AI. Increased venous return and respiratory compromise. Okay. See, did you guys get that one? Now, Trendelenburg, patient is lying back, lying flat on their back. Laparoscopically typically involves blowing up the belly, right, of the abdomen. So their CO2 gas is expanded into the abdominal cavity for better visual um, visibility of whatever we're working on, whether it's the appendix, whether it's the gallbladder, liver, whatever. Okay. So how you might see it more integrated. When a patient is placed in Trendelenburg for a laparoscopic procedure, what should you anticipate will happen to the abdominal organs, and how might that affect breathing and circulation? Okay, so then we think about gravity, the organ shift, we think about respiratory, cardiovascular implications. A lot of times anesthesia has that on lock, but we're still kind of thinking about it as well. Okay. Question 8. During a carotid endarterectomy, what is the primary reason for using a shunt? Now, this is going to be important because you got to think about, what are we placing a shunt for, right? Well, we know to maintain cerebral perfusion during arterial clamping. And so I wanted to get a image of it clamped. Think about where this blood is flowing to, right? It's flowing to the brain. Now, we're trying to remove plaque from the carotid artery. So what kind of instrument or equipment can we use from one of the first questions that we had in the beginning of the day or the live session? We can use that, right? The Fogarty. Yes, we can use that. Now, during the procedure, we look at what's being clamped, right? The carotid artery is clamped. That's going to temporarily stop the blood flow to the brain on that side, whether it's left or right. Okay. Now, when that artery is clamped, blood flow to the brain obviously is not getting there. So we have to place that shunt to kind of bypass. It goes back to when you are driving in the street and there's road work and they've got cones everywhere so they can work on the road, and then we bypass it. That's going to be on surgeon's preference and the patient, how the patient is, like the patient's condition. Great question. So, got to keep in mind that there are so many other factors that are going to go into why we place what we do. Okay. Now, the reason why we do not want to just clamp off that artery and be like, let's keep moving, is because, well, the patient can stroke out. And we really don't want that during the operating room, right? Like, who wants a patient that could potentially kind of stroke out because we forgot to place in a shunt, which won't ever happen, but just so you know, things to kind of think about. Now, our focus. During a carotid enterectomy, we already know what we're doing. If the artery is clamped, what do you need to be thinking about in terms of brain perfusion? How does a vascular shunt protect the patient during this time? Again, we are prioritizing cerebral protection during a vascular surgery. We're trying to understand why specific instruments like shunts are used, not just what they are. Okay. You're thinking, yes, blood flow to the brain. You're thinking beyond the field and considering system wide effects, which is a hallmark of what we do. Because remember, a lot of times we are thinking 3 and 4 times ahead of the case just so that we are prepared. The biggest thing is kind of understanding these procedures, especially if you hadn't had the opportunity to get into them yet, right? When we're talking about a CEA, which is a carotid enterectomy, we're removing plaque from the carotid artery itself. We're trying to prevent a stroke, and the artery has to be temporarily clamped. That's the only way that we can get in there and clean out that plaque from the artery. Okay? Keep in mind, the shunt is helping with cerebral blood flow back to the brain on that side. I picked out 2 more questions, I believe. Okay. Now, this is a sterilization question. Which sterilization method is most appropriate for heat sensitive, moisture sensitive surgical instruments such as fiber optic endoscopes? Okay, we're talking about ETO. All right. The question is about sterilizing instruments that can't be handled with a lot of heat or a lot of moisture. So your fiber optic endoscopic instruments, again, they're very delicate, they're complex, they're sensitive to both heat and to water. Now, when you're preparing a fiber optic scope for sterilization, what factors should guide your method choice? And why is ethylene oxide preferred over steam or dry heat in this case? So let me give you guys a caveat of how I've done these questions. 9 times out of 10, and I'm telling you guys at question 9 times out of 10, the question's going to stop here at when you're preparing a fiber optic scope for sterilization, what factors should guide your method choice? Question mark. I added the other additional to these questions to kind of help you to think outside the box of what the question's asking. And then that can kind of help bring it together. Okay. Now, the question is looking at different things. We're considering the properties of the instrument. Is it sensitive materials? Does it have internal channels? Then we match those properties to the appropriate sterilization method. We're recognizing when damage prevention is priority over speed. So some of the instrument types that we're thinking about: fiber optic scopes, cameras, plastic devices with lumens or delicate seals, or anything that cannot tolerate high heat or moisture. And the last question I picked out: what condition occurs when the alveoli are permanently damaged? Okay, so you have supposed to be a caricature of a healthy and one that's not so healthy. Um, emphysema. Emphysema, that's correct. Now, permanently damaged alveoli. The tiny air sacs in the lungs lose their elasticity and ability to exchange gas effectively. That's what the image was supposed to be showing. Okay. Um, but why is A correct? We're talking about emphysema. This is a chronic condition, right? But with emphysema, the alveolar walls are destroyed. And this is causing the alveoli to kind of enlarge. And it's like a balloon that's popped. Once that balloon has lost its elasticity, you can't bring it back together. This leads to poor gas exchange, air trapping, and this is when the patient has that difficulty breathing. It's part of COPD, which is chronic obstructive pulmonary disease, and that's often caused by just smoking. Okay. Now, why are the other ones incorrect? With cystic fibrosis, this is a genetic disorder that affects the mucus production in the lungs and in the digestive system. With cystic fibrosis, believe it or not, the alveoli aren't permanently destroyed, but what's happening is that mucus is going in there and it blocks the airway, and that's what causes infection because it's trying to bypass or get through all that mucus. The next one was hemostasis. This is where the patient is coughing up blood, which is a symptom, not a disease. This can occur in a lot of different conditions, TB, pneumonia, cancer, but it's not necessarily related to the alveolar destruction. And then asphyxia. This is where there's just lack of oxygen because there's some type of impaired breathing. The patient could be choking or, in a burst scenario, strangulation. This one, asphyxia, is an acute emergency, not a chronic alveolar condition. Okay. If the question mentions permanently damaged alveoli and difficulty exchanging gases, what conditions should immediately come to mind? Question mark. Okay. That's how the question would be presented. And then you'd have your choices. And of course, we would choose emphysema because we're rock stars. But then to take it a next step, how does this affect the patient's ability to oxygenate over time? This is where we start thinking about permanent damage, chronic respiratory disease. We have to differentiate between emphysema from other pulmonary conditions that affect breathing in different ways. Think of the functional impact, not just like what the book is telling us, right? So we lock in some keywords: permanently damaged alveoli, loss of elasticity, poor gas exchange, chronic condition. We go back to our options and then we can start crossing different things out. Emphysema is the correct diagnosis because the alveolar wall breaks down. Air sacs are being expanded. Think of that balloon. Once it gets too big, it pops. There's no coming back. It causes air trapping, that barrel chest appearance, and shortness of breath. It is strongly linked to a smoking history. Now, that's not saying everyone who has it, it's just that's what it's linked to. Okay. Now, how do you feel about the questions that you just kind of went oh, you kind of took, and what we just reviewed? Because now we're going to get into our refine, recover strategy, but I don't want to move on until I know you guys feel pretty comfortable. Everyone's quiet. Are you guys ready just to get it out of the way and knocked out? Okay. Thank you. All right. Now, yes, Nareen, you understand a little better. I love that. Good review. The floor is yours.
I wanted, sorry, I wanted to review the microscope question too, but I got it wrong and I was confused between two answer choices. So can we discuss that question too,
Is
please?
that the one you sent me via email?
No, no, no. In the quiz that we just took,
Okay. I have to go
it
back to
was
see
like the
which
second
questions.
or third question.
Second. Okay, hold on. I'm gonna open up the give me un momento por
Sorry.
favor. Because I don't want to go back here. I'm gonna go here and get the question really quick. Talk amongst yourself while I find the question.
It was like, which choice is correct regarding microscopes?
Okay. So question number 2. I think I found it. Okay. Let me close this off because I'm going to see 2
Yes, thank
slideshows
you.
here. Okay, got it. All right.
Thank you.
So the question is, which of the following best reflects proper sterile technique and equipment protection when applying a surgical microscope drape? Was that for the week quiz? Okay. So we had the microscope is always draped before the timeout begins, regardless of the procedure type. The drape must be carefully applied to avoid obstructing essential optical components. Only sterile team members should handle the microscope during draping to avoid contamination, and draping is limited to eye procedures like cardiac extraction and rarely used elsewhere. First thing that we're going to do is eliminate the one that should not be there. Which one should be right off the bat thrown out? Did I say it right? Hold on. The microscope drape should never cover ocular lenses. Is that the one you guys are looking at? Was there another one? Okay,
No,
perfect.
that's the one.
Okay, okay. I was like, wait a minute. I want to make sure that I have the right one.
Okay.
So let's eliminate some now. Okay, we got that one. Never after a timeout because that's going to be a little bit too late. Okay. What's another one that we can eliminate? How about a non-sterile team member must assist with microscope draping? The drape is a sterile item, so it's going to be applied by sterile personnel. Now, again, we've been out in the field a little bit, so we know, right? We know that we know. However, we're going back to the book. So when we talk about the book, we're looking at a non-sterile team member might assist by positioning or adjusting the equipment kind of like beforehand, bringing it down, getting it ready so that we can pull it on. But technically, they cannot apply the sterile coverings, right? Now, they may adjust and help from the inside, but they're not going to be touching the outside, okay? And then the intraoperative microscope draping is typically only performed for cataract extractions. Well, we know that's not true, right? Because the microscope use is for so many types of surgeries, not just cataract extractions. So if we just went by that, what answer is left? Because we're going to go back to it, but we've just eliminated the other three. Now, why is the microscope drape material should not cover up the ocular lens correct? The ocular lenses are the eyepieces, right?
Yeah.
They have to remain clear and unobstructed. So if you've gotten into these cases, you'll notice that the surgeon is going to take that plastic piece off. We don't do it. And you may not have noticed when they've done it because you're doing your thing, but they're going to take that piece off and toss it. Normally, they just kind of toss it because it has a perforated edge around the eyepieces. We still do our due diligence and drape it to keep it sterile until they doop, doop, take it off. Now, again, Yasmin said it perfectly. They can't see if it's obstructed. Even though the plastic is clear, it will do a lot of obstruction. So they have to remove that piece. Okay. Does that make sense? Awesome. Just in case you see a concept like that on the CST exam. All right. Any other questions? Let me pull back up the other slide just in case there are any other questions that you guys can think of. Nothing yet? Okay. All right. Now we're getting into, hold on. I got another question. Let me go find it. Let me go down. Question 29. I kept the other one up just in case. Okay. Question 29, let me make sure I am cross-referencing. I'm trusting myself, but I'm also verifying. What is the mechanism? Okay, got it. Okay, so the next question that we'll cover really quick. What is the mechanism of action of SUX as a neuromuscular blocking agent? Now, the correct answer was B, right? But why? First thing we're going to do is eliminate the other ones first. Okay, so we know the correct answer, but why are the other ones incorrect? And sometimes this is the easiest way to kind of help us prepare. Okay, now A states that it inhibits, oh my goodness, acetylcholinesterase. See why I didn't go into pharmacy? To prolong muscle contraction. Okay, so I should say A. So A is incorrect. Okay, because it describes how it increases acetylcholine levels at the synapses. So think very, very close to your neural synapses. Okay. Sucks does not inhibit that word. Instead, it kind of mimics. Okay. So we're going to take out A because it's not going to help with inhibiting anything. It's actually mimicking what it does. Okay. B, go back to here to make sure I'm getting it right. Okay. Is the correct answer. So we'll go back to that one. C, blocks calcium channels in skeletal muscle fibers. Why is this one incorrect? Remember, SUX does not directly affect calcium channels. Calcium channels or calcium channel blockers have a lot of other roles, like they're the ones that affect our heart, like our cardiac and smooth muscles, not skeletal neuromuscular blockade. So, okay, C is knocked out, A is knocked out. So then that leaves B and D. But let's eliminate D too. Stimulates the release of norepinephrine from nerve endings. Now, this describes some simple mimetic drug or a drug that's not a neuromuscular blocker, because I'm saying the words wrong and I don't want to mess them up. It's not a neuromuscular blocker. SUX acts peripherally at the neuromuscular junction, not as an adrenic nerve terminal. So it's not going to the nerve terminals. Now, if the drug itself causes initial muscle, like that twitching, followed by paralysis, I want you to think SUX and its depolarizing action. Okay. Thank you. Except I can't say these pharmacological words. You should see me in pharmacy. I'll be like, SUX. This is what we say. We're not necessarily saying succinylcholine. So that is how we eliminate it. So we've got A eliminated, C eliminated, D eliminated. So then we go back and we're like, okay, the rest of them just don't work. What does B do? It competes with that word at the neuromuscular junction and causes sustained depolarization. The biggest key for this one is it has, luckily, neuromuscular in it. And since SUX is a depolarizing neuromuscular blocker, the other three just don't fit. It has the word we need. And this isn't a clutch, like you're like, I'm going to just guess. 9 times out of 10, you're going to get it right because you've already eliminated the ones that just don't fit. Okay. Keep in mind that it's not, SUX isn't broken down quickly. So it causes continuous stimulation and depolarization. And that leads to that muscle like paralysis after like that initial like twitch. Okay. So it's like a twitch and then it's loose. That makes sense. Any other questions? I'm going through and I still have the other one up. So that way I can kind of keep, if something else arises, I can kind of keep a reference because I have on my little notes everything. Okay, wait, I got one more question. What does sunken eye mean? Okay, this is a condition where the eyes appear deeper into the eye socket more than normal. It can mean there's other issues that you would see aging, unfortunately, which is where we lose our fat, which is good, just not in that place for me at least. It could be a sign of significant weight loss. Let's say a patient doesn't get enough sleep. It can be medical conditions like, uh, let's say the patient got in a fight and there was a blowout fracture, then that would cause it to kind of sunk in. And then it could be from post-surgical changes as well. There are some syndromes that I'm not comfortable with. So you can kind of look that one up. I don't want to give you guys the wrong or, like guess and give you, well, I think it's this. There are some different syndromes that can also make it look like it's sunken, but that's what it is. It's where it kind of like retracts back. Great questions, by the way. Okay. Anything else? All right. Now for our CST focus. Okay, so I put up some stuff to kind of help you guys where you're refining. I don't want you to cram, even for the 600, if you're taking it first time, my 700s, you guys don't cram. You guys know this just by the question you're asking. You're asking the right questions, okay? Um, Use your textbook like it says, practice some cases just to kind of tighten any little gap that you may feel. Just like we did today with these poll questions. Go back to some CST questions to kind of stimulate the CST format, but try to do it without your notes. Give yourself a time limit. Like if, let's say you do 15 questions, do 30 seconds a question. So with 15 questions, set your time for 7.5 minutes and just knock it out. Okay. And then recovery is really important with performance where you're getting good sleep, you're going through stress techniques just to kind of recharge. Okay. Can't believe we're already here. Focus your energy where it matters most. And so I kind of put up an example. This one is kind of blurry. I use this in my theory 3 course where I break down just suture types and how they can really be able to identify it. So things that confuse you, you can kind of write out charts. Again, your textbook is right there. Don't just reread it, kind of really challenge yourself so that you can explain the concept out loud like you're the one teaching it. Sometimes when you teach back, you'll be surprised at how much you're like, oh, yes, I know this. Okay. Practice like it's the real thing. Just like we kind of did today, it was a very shorter version. I know 30 questions, but you had a timer. Okay. Some of you may have used your notes, you know, that's okay. But just keep in mind for the real mock and the real CST, you're not going to be able to have your notes. So try to set yourself up just even if it's just one more time before the mock and before the real one, where you literally make up some questions or grab some questions that you may have had difficulty on, type them up, set your timer, and then go. The biggest thing is we did 30 questions today. You guys only had 15 or what is it, 15 minutes. Okay. Aim for 25 to 50 questions, review your answers, and then just like we did over the last 11 weeks, what is the question asking? How can I eliminate the other ones? Why is this the best answer out of the 4? Because a lot of times you'll have 2 answers that are like, oh, okay, these are pretty good, but why is this one more correct than the other one? Okay. And then here, you guys get your breaks in. We had our techniques. Would you guys, because I haven't done it yet, would you guys like me to kind of recap all 11 stress managements and kind of put it in one little section for you guys to kind of review? Again, I haven't done it. It wouldn't take long, or I can kind of like have one sheet and it would just be stress management 1 through 11, because I can do that. I think I can do that today. But if it's not going to help, I don't want to cause extra stress on you guys because that would be crazy. Here's a stress management for extra stress. So you guys just think about it and let me know. Okay. Now, after a 45-minute study session, and this is not just for this class, for any time, take a 10-minute break. I try to do that at the 45-minute to 60-minute. If you notice, we will take breaks, or we did take breaks, okay? Whether it's just to kind of stretch your legs, to breathe, to hydrate, but not think about, oh my goodness, I've got this mock coming up. Oh my goodness, it's the real CST. Oh my goodness, I'm about to graduate. How's my hair going to look? What outfit am I going to pick out? Okay. And repeat. What still trips you up? If you've gone through 20 questions and now 5 are a little bit more of a struggle, break down those 5, retake the entire 20, and then see how you do. This is where refine, rehearse, recover comes from. We look at the top 3 topics I am going to review before the CST. This is for you guys, okay? You can take a screenshot. I'll probably have this in the archive section for y'all. Not a requirement, of course, just an additional resource if you like to use it. Okay. Again, this is not a requirement, but you pick out your topics. You can use Quizlet, case walkthroughs. You can go back to our archives, grab a question that we covered in one of the archives. Don't try to relearn it. Okay. You're just patching in the cracks because you already know it. One test taking habit I will use to stay focused on, something else that you can do. Again, we've done this. We eliminate two wrong answers right away, right off the bat. This one and this one, it's a no go. Okay. Reread every not question twice. This is what really gets me sometimes because I'll go through, I'll skim through, and I won't catch that not until later. And I'll be like, oh, wait, let me go back. And then I'll read it again. And I'm like, this is a not question. In your mind, I don't know if you guys have scrap paper, but circle items like sterile or primary purpose, or kind of write them down if you're allotted scratch paper, because that's going to help you as well. And this is the big one. Be real with yourself. This is about mental prep just as much as it with anything else. It's not just content. For example, you see the question, like let's say there's a trap, okay? Think about, and this, I'm going to use myself. I freeze when I don't know the answer. I start to kind of start breathing a little bit harder. I feel the heat coming and I'm like, oh my goodness, oh my goodness. So I start to think about my response. I'll take a deep breath. I'll eliminate what I can and then I'll move on and then return if I have time. What I've learned is to not get caught up on those questions that I freeze on because I know the information. It's just at that time, for whatever reason, I've let my anxiety take over. So by leaving and going to another question where I build that confidence back up, I start my breathing again, I'm able to go back and usually I'll get the correct answer. Okay. So that's kind of why I put my responses on there so you can see I put on my clothes just like you guys do. All right. Why? Because mindset matters just as much as memorization. We're training our inner voice to kind of coach us and not criticize and get into our heads. Okay, because that's a big one. And the night before. This may be hard because life's, but try to get, like you see, at least 7 hours of sleep. Lay out your ID, your clothes, everything that you're going to need. Okay. Do one light review, then stop. And I mean like super light, like just brush on something that you're like, let me just check up on this one more time and then cut it off. Okay. It's just a suggestion. Um, Try to walk, music, prayer, if that's, something that can really help you. Remind yourself, as it says up there, I'm prepared. I've done the work because you have. You guys, you're not winging it. You're walking in trained. You guys know this stuff. You've practiced, you reviewed, you've corrected, you've refined. Now it's your time to trust your prep, trust your pace, and show what you know. Now, for those of you that have already taken the survey, we are looking to hear what you think. Me personally, I want to know what I can do better. Okay. I want to know how I can serve you guys, how I can improve. Um, so I really want to know what worked, what didn't work, what you would have liked to see. Um, if you've already taken the survey, enjoy a second. We'll earn 5-minute break and then we'll come back and get into our stress management 11. We'll have some final words. Not final, not final. We'll have some closing remarks and then I'll get you guys out of here. So I will see you in 5. Again, if you've already taken it, thank you, thank you. If you haven't, please, please, please let me know so that I can better myself and see, what's going on. Here we go. I love that little music. Let us know. I know some of you guys have to get out of here. I thank you guys. We just have our final push. Sometimes social support is important, and this is just what our last one is. For those of you who are leaving, I know it's getting close. Just make sure you check the final remarks. I'll put it in my closing remarks, a timestamp for you guys. Okay. But I get it. Life is lifing. Um, so the last one is just seeking support. You guys have been through a lot. This is not an easy program. So identifying different areas does help. Don't go in it alone. Talk to someone, a peer, a friend, your family. It does help you feel grounded, supported, and not alone. Okay. This is your moment to prove what you know and trust how far you've come. If you do have any questions, you guys just send them to me. I will do what I can to kind of post them so that everyone can see, so that, if you need a little bit of push. Now, before we get out of here, like I said, I am going to timestamp this closing remark for everyone. Okay, here we go. It actually has truly been an honor taking this ride with all of you the past 11 weeks. Each and every one of you should be incredibly proud of what you've accomplished this far. For the 600s, you're about to take your first mock, I believe, right? This is a major milestone. You know what areas you need to work on. We've kind of given you a blueprint. Stay focused, trust your progress. Don't let any setbacks define you. Keep pushing forward and remember growth is process, not a destination. To the graduates, an ST 700, 710. I want you guys to take a deep breath. Seriously, take a deep breath. You just have one mock exam left, and then it's showtime. I want you to continue to learn, continue to grow, and never let anyone steal your joy. Be proud of who and where you are and everything you've achieved to get here. Remember, believe you can. You're halfway there. You've done the hard work. Now I want you to trust your preparation, believe in yourself, and finish strong. Why? Because that CST title is waiting for you. With that, this is crazy. It's going to be the last time I say this for you guys. Okay. With that, I wish you all the best. You guys have a wonderful evening. Have a wonderful rest of your week. Um, this is not goodbye for those that are getting ready to graduate. It's see you soon. With that, good night and good night, everybody.